Aphthous ulcers, often called canker sores, are painful inflammatory lesions or spots on the inside of the mouth. Most often, people develop minor aphthous ulcers, which is where the lesions are a few millimeters across, round or oval in shape, and disappear within a week. There are also two other unusual variations, though: major aphthous ulcers and herpetiform ulcers, which are more severe and debilitating. The underlying cause of this inflammatory disease is not well understood. One theory suggests tissue specific autoimmunity, where a localized cell mediated immune reaction happens in the oral mucosa, creating an accumulation of T cells, specifically T helper cells or Th1 cells, and macrophages, as well as chemokines like interferon gamma and tumor necrosis factor. Aphthous ulcers typically arise either singly or a few at a time, on the inside of the lips and cheeks or under the tongue. Initially, there's a small raised bump of inflammation in your mouth, and as it heals, it turns into an ulcer covered by a fibrous membrane cap that looks yellowish white or gray with well defined margins. The ulcer is typically surrounded by a characteristic red halo due to inflammation in the neighboring blood vessels. Aphthous ulcers are usually mildly painful and annoying, with individual lesions measuring a few millimeters across and healing within 7 to 10 days without scarring, and these usually recur 3 to 4 times per year. There are some variations on this general pattern, though. Some individuals have recurrent aphthous ulcers, which is where the recurrence is more frequent, sometimes each month, and this starts during childhood and resolves around age 40. Another variation is major aphthous ulcers, which describes lesions that measure over 1 centimeter in size and are generally more painful, last longer, and recur frequently. Major aphthous ulcers can take between 10 days to over a month to heal, and can also leave a scar. Finally, there are herpetiform ulcers, which typically affect women, and despite their name, are not linked in any way to the herpes virus. Herpetiform ulcers start out as clusters of tiny discrete ulcers that coalesce to form large, ulcerated patches in the mouth. Although they heal in about 10 days, new crops of ulcer recur so frequently that they're effectively continuously causing pain and difficulty with eating and drinking. Aphthous ulcers are non-contagious, non-sexually transmissible, and idiopathic, meaning that it's not clear why some people get aphthous ulcers and others don't. Many people with aphthous ulcers, though, do have family members with the same problem, so there could be a genetic link. There are also well-known external triggers, like a physical injury inside the mouth, like a bit lip, badly fitting dentures, or overzealous toothbrushing, which can all trigger the development of a lesion, as well as stress and anxiety, which seem to play a role in the pathogenesis of various inflammatory diseases. Individuals with systemic immune system disorders like celiac disease and HIV infection are more prone to getting aphthous ulcers. And it's also pretty common for people with nutritional deficiencies to have recurrent ulcers, which might be improved with diet and nutrient replacement. It's also common for people who stop smoking to develop aphthous ulcers, but it's unclear if this is a direct effect of tobacco preventing ulcers or indirect factors like increased stress and anxiety while quitting smoking. A detailed history, along with the typical appearance of an aphthous ulcer, is all that's needed to make a diagnosis. But aphthous ulcers can also pop up as a symptom of other systemic immune system disorders, like Crohn's disease, so occasionally a more extensive workup is done. There's no cure for aphthous ulcers, so the main goal is to identify and avoid triggers. Sometimes topical analgesics and corticosteroids can be used to relieve pain and inflammation. Alright, as a quick recap, aphthous ulcers are small, painful sores inside the mouth that are most often triggered by trauma inside the mouth and take about a week to heal. The underlying cause of aphthous ulcers is unknown, but it seems to be an autoimmune process in the oral tissue that involves Th1 cells, which can also sometimes be related to an underlying systemic disease. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media. Oral cancer describes cancers that originate in the oral cavity. The oral cavity includes the lips, the gingiva, or gums, the floor of the mouth, the buccal mucosa, which is the soft lining of the inner lips and cheeks, the anterior or front 2/3 of the tongue, the hard palate, which is the tough front part of the roof of the mouth, and the retromolar trigone, which is the mucosa right behind the last molars on the bottom row of teeth. Behind the oral cavity is the oropharynx. The oropharynx includes the soft palate, which is the soft part of the roof of the mouth right behind the hard palate, the tonsils, the walls of the throat, and the posterior or back 1/3 of the tongue. The oral cavity and oropharynx are lined by epithelium, and there are a few different types. The first type of epithelium is called keratinized stratified squamous epithelium. These epithelial cells produce keratin, a protein that makes the layer tough and protects against normal wear and tear from food and drinks. Beneath the epithelium, there's another layer called the basement membrane, made of tough connective tissue. And below that, there's the lamina propria, which has yet more connective tissue that houses blood vessels, lymphatics, nerves, and immune cells. The oral surfaces covered in keratinized epithelium include the hard palate, the dorsal surface, or top of the tongue, and the gingiva. A second type of epithelium is non-keratinized stratified squamous epithelium, and it contains cells that don't produce much keratin, making this layer less tough. The oral surfaces covered by non-keratinized stratified squamous epithelium include the buccal mucosa, the floor of the mouth, the lateral and ventral or bottom surfaces of the tongue, the soft palate, and the retromolar trigone. Now, the mucosal tissue in the oral cavity can undergo several pre-malignant pathological changes. The first one of these is leukoplakia, where leuko means white and plakia means a flat, raised patch or plaque. And leukoplakia specifically relates to a white plaque with no clear underlying cause. These leukoplakias are usually painless, but can't be easily scraped away. Now, the exact cause for leukoplakia is unknown, but a known risk factor is tobacco use. Early on, these lesions are usually pretty thin, so it's called thin leukoplakia. These can either go away on their own, remain unchanged, or grow and become thicker, at which point it's called thick leukoplakia. If it becomes bumpy, it's called nodular leukoplakia. And if it becomes wart-like, it's called verrucous leukoplakia. Now, a more serious form of leukoplakia is called proliferative verrucous leukoplakia, which usually affects women with no risk factors. And it has a predilection for gingival tissue and causes multiple rough white lesions that grow and spread. And in most cases, eventually it develops into squamous cell carcinoma. At the cellular level, leukoplakia typically shows a thickened keratin layer. Since keratin absorbs water, a thick keratin layer looks white when it's wet. Leukoplakia might show cells that have undergone some degree of dysplasia, meaning that they look abnormal in some way, but are not cancerous or malignant yet. However, leukoplakia is considered a precancerous condition, meaning that compared to normal tissue, it's more likely to develop into a cancer in the future. And that change could happen at the microscopic level, meaning that the lesion might look the same on the outside, even though the cells have become cancerous. Generally speaking, the transition from dysplastic cells to malignant cells happens gradually. And as cells become more and more dysplastic, the lesions sometimes develop red spots. And at that point, it's called erythroleukoplakia. Cells in these red areas have suffered serious damage to their DNA, and don't mature normally and therefore can't produce keratin. And as they become more and more atypical, the more immature becomes the epithelium, and it'll start becoming thinner or atrophic, and allow more of the underlying blood vessels to be seen through the mucosa. At that point, the lesion will be completely red, and will be called erythroplakia. Erythroplakias are more serious than leukoplakia, because almost always when they're removed and examined under the microscope, they'll show severe dysplasia, or early cancer. Now, a lesion that looks like leukoplakia but isn't is an area of frictional keratosis. That's where there's repeated physical trauma like rubbing of the tooth surface against the mucosa of the cheeks. For example, after a dental procedure that leaves a rough tooth surface, or a broken tooth rubbing against the mucosa. It's a normal hyperplastic response, meaning that the epithelial cells in the area divide more than usual and build up a protective layer of keratin. It's kind of like developing a callus on your hands after spending the weekend raking leaves. An area of frictional keratosis is not a precancerous lesion, and usually fades away once the irritation stops. Most of the oral cavity is lined by stratified squamous epithelium, so the majority of cancers that arise are squamous cell cancers. Squamous cell cancers arise from squamous cells that undergo genetic mutations that either activate proto-oncogenes or inactivate tumor suppressor genes. When proto-oncogenes like epidermal growth factor receptor and RAS are activated, it turns them into oncogenes that promote cell division. And when tumor suppressor genes, like the genes that encode proteins p53, p16, and the retinoblastoma protein, also called PRB, are inactivated, it removes the inhibition to cell division. So together there's uncontrolled cell division, which can give rise to a tumor. As the cancer cells divide, they can sometimes gain the ability to penetrate through the basement membrane. And at that point, it's considered a malignant tumor. The malignant cells then invade surrounding tissues like the salivary glands, muscle, and even get into the blood and lymphatic systems, and metastasize or travel to other areas of the body. It's kind of like a toddler learning to get out of the crib and then running rampant through the house. Proliferative verrucous leukoplakia can turn into a particular type of squamous cell cancer called verrucous carcinoma. And it's also sometimes called snuff dipper's cancer, since it's more common among users of snuff and other forms of chewing tobacco. Generally speaking, malignant cells are irregularly shaped with darkly staining nuclei, enlarged nucleoli, and produce abnormal keratin that look like pearls, so they're called keratin pearls. Co-carcinogenesis is necessary to cause oral squamous cell carcinoma. That means that more than one carcinogen, or causative factor, is needed to cause the disease, like abusing alcohol and using tobacco. Many carcinogens come into contact with a wide area within the oral cavity and oropharynx. So the idea is that they cause field cancerization. This means that the entire contacted area or field undergoes genetic changes and is more likely to develop cancer in the future. In addition to squamous cell carcinomas, other types of oral cancers include adenocarcinomas, which develop in glandular cells like those of the salivary glands beneath the mucosa, extranodal lymphomas, which develop in lymphocytes, and melanomas, which develop in melanocytes, found all over the mucosal epithelium, but most often in the hard palate. Squamous cell carcinoma is also known to arise at the lip vermilion in those who smoke, right at the location where a person holds the smoking device, like a cigarette or pipe. However, most lip vermilion cancers result from chronic sun damage and are associated with actinic cheilitis, a precancerous rough patch on the lip. The most common locations for oral cancer are the lateral and ventral surfaces of the tongue and floor of the mouth, and the lower lip vermilion because it's exposed to more sun than the upper lip. Well-known risk factors for oral squamous cancer include tobacco smoking, alcohol abuse, chewing betel quids or pon, UV radiation, exposure to metal dust or chemicals like phenoxyacetic acid, vitamin and mineral deficiencies like a severe form of iron deficiency called Plummer-Vinson syndrome, and various immune deficiencies. Oropharyngeal cancers are strongly associated with infection by human papillomavirus type 16. But interestingly, tumors of the oral cavity, like the lateral tongue and floor of the mouth, are not usually associated with HPV-16. The symptoms of oral cancer include numbness or changes in sensation in the mouth and throat, a hoarse voice, pain or difficulty with chewing or swallowing, and both painless and painful lumps, sores, or discolorations in the mouth that don't heal. Signs of precancerous development include areas of leukoplakia, erythroplakia, and erythroleukoplakia, or any other abnormal appearing tissue or masses. In other words, white or red lesions without an obvious traumatic source and have a rough, irregular, velvety, or speckled surface are all ones to look out for. As the tumor grows, some become exophytic, where it grows outward, or endophytic, where it grows inward. Diagnosis typically includes a biopsy of the tissue, because the cancer has to be confirmed histologically. A lymph node biopsy and imaging, such as an X-ray, CT, or combination imaging like PET-CT, might be necessary for tumor staging. The staging system consists of T for the primary tumor size and involvement of surrounding structures or muscles, N for the number and location of involved lymph nodes, and M for metastasis, which denotes whether distant spread of the cancer has happened or not. Generally speaking, the higher the number assigned to any of these components, the higher the stage, and the worse the prognosis. While the prognosis of squamous cell carcinoma in the oral cavity depends largely on the tumor stage, HPV status is a main prognostic factor for squamous cell carcinoma in the oropharynx. Treatment of precancerous lesions starts with active surveillance, removing any diseased tissue, and stopping any causative agents, like smoking and alcohol abuse. Malignant lesions are mainly treated by surgery, but some cases also require chemotherapy or radiation therapy. And ideally, these lesions are caught early so that they can be better managed. That's why it's important to screen for oral cancers, like with a routine head and neck exam in the dental office. That's where it's good to look for early lesions, which are often red or white plaques with an unknown cause. Alright, as a quick recap. Oral cancer refers to cancers that originate in the oral cavity, which is lined by keratinized or non-keratinized stratified squamous epithelia. Leukoplakia is a precancerous white lesion, but more serious lesions include the red-colored erythroplakia, which almost always contains severe dysplasia or early cancer. Risk factors for oral cancer include alcohol abuse, tobacco smoking, and using betel quid, as well as immunodeficiency and nutritional deficiencies. Diagnosis includes a biopsy, while treatment might include surgery, chemotherapy, or radiation therapy. Sile refers to saliva, adin refers to a gland, and itis is inflammation. So acute sialadenitis is the sudden inflammation of any of the salivary glands. The major ones being the parotid, submandibular, and sublingual gland. Sialadenitis usually affects a single parotid gland, rather than both, and is most common among individuals in their 50s and 60s, but can happen at any age, even in a newborn. Acute sialadenitis is most often caused by the bacteria Staphylococcus aureus, but may also be caused by Streptococcus viridans, or by Haemophilus influenzae, as well as viruses like mumps and HIV. When it's a bacterial infection, it often starts up after a salivary duct is plugged by a salivary stone. Salivary glands secrete saliva through tiny ducts in the mouth to help lubricate the inside of the mouth and also moisten and soften food. The antibacterial properties of saliva and the quick flow through the salivary duct both help to prevent infections from developing. But there are various factors that reduce the rate of salivary flow, like dehydration, illness, and certain medications. These factors can allow deposits to settle in the walls of the salivary duct, physically blocking the path and further slowing down the flow of saliva. This can allow tiny areas of stagnation, where more deposits of calcium, phosphorus, and other electrolytes can precipitate out, ultimately forming small concretions called microsialoliths, or tiny salivary stones. Over time, these can grow into sialoliths, which are larger salivary stones. Salivary stones block up the duct, which allows bacteria to move from the mouth, up and around the blockage, and into the salivary duct. And this results in inflammation and tissue swelling, which can further compress the salivary duct and worsen the problem. Acute sialadenitis causes pain and swelling as well as redness of the skin overlying the affected gland. Because the salivary gland is affected, it also means that less saliva is being made, which dries out the mouth, and can cause a bad taste in the mouth from pus leaking out of the affected duct. Severe sialadenitis can also make it painful to open the mouth, which can make eating and drinking tough as well. Like any severe infection, it can cause fever and chills, and also develop into an abscess. Chronic sialadenitis, in contrast, is less painful and causes the gland to enlarge following meals, typically without the overlying redness of the skin. The chronic form of the disease is associated with conditions linked to chronic decreased salivary flow, rather than from dehydration. One mechanism for this would be when an acute episode of inflammation leads to salivary duct fibrosis, which alters the glandular tissue and the composition of the saliva itself, making it more viscous and slow-moving. In other cases of chronic sialadenitis, there might be an autoimmune disease, like Sjogren's syndrome, which causes chronic inflammation and salivary duct fibrosis. Diagnosis of sialadenitis is generally based on a swollen salivary gland, and laboratory culture of pus, which can be collected by gentle compression, or milking of the gland. Imaging can also be helpful to check for an abscess, salivary stone, or a tumor. With regard to treatment, hydration and glandular massage are both helpful in stimulating salivary flow, and antibiotics can help to treat an infection. Medications that stimulate saliva production can help clear the salivary duct as well, but individuals with recurrent disease might need partial or complete surgical removal of the affected gland. Alright, as a quick recap, sialadenitis is inflammation and swelling of the salivary gland. Acute sialadenitis is typically caused by a bacterial infection like Staphylococcus aureus, which can get established when a salivary duct is plugged up by a salivary stone. Chronic sialadenitis is generally associated with decreased salivary flow, which might be caused by salivary duct fibrosis after an acute infection or an autoimmune process, both of which can lead to recurrent infections. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media. Temporomandibular disorders are a group of disorders that all involve the temporomandibular joint, which is located between the temporal bone of the skull and the mandible, or jawbone, as well as the muscles and associated structures that are involved in chewing and speech. Normally, between the temporal bone and the mandible is a synovial cavity, which is wrapped in fibrocartilage and filled with synovial fluid, which is a protein-rich fluid that reduces friction between the sliding bones. The synovial cavity is divided into an upper and lower compartment by an articular disc within the synovial fluid. The lower compartment is bound inferiorly by the condylar head of the mandible. The lower compartment allows the mandible to rotate, which lets the mouth open and close. The upper compartment is bound superiorly by two regions of the temporal bone, the mandibular fossa in the middle and back, and articular tubercle in the front. Separating these two compartments is the articular disc. The upper compartment allows the condylar head to move forward and rotate. The movements of the temporomandibular joint are coordinated by numerous muscles, including the temporalis, which is a fan-shaped muscle on both sides of the cranium, the masseter, which connects to the mandible and the zygomatic arch of the temporal bone, the medial pterygoid, which connects to the mandible and medial aspects of the lateral pterygoid plate, and the lateral pterygoid, found at the condylar process. These muscles are innervated by branches of the trigeminal nerve. Now, the causes of temporomandibular disorders can be categorized as intra-articular, within the joint, or extra-articular, involving the surrounding musculature. Intra-articular causes are called temporomandibular joint disorders, and they include things like abnormalities of the bones in the joint, inflammation in the joint from conditions like osteoarthritis or rheumatoid arthritis, disorders of the articular disc, laxity of the fibrocartilage, allowing for temporomandibular hyper or hypomobility, or trauma that might result in structural damage or bleeding inside the joint. Extra-articular causes are also called temporomandibular muscle disorders, and they include things like overuse of the masticatory muscles, like in bruxism, which is teeth grinding or jaw clenching, as well as chronic muscle spasms or muscle inflammation. The main symptom of temporomandibular joint disorder is pain or tenderness, especially with movement of the jaw, like when chewing. The pain can also radiate, causing headaches, toothaches, and earaches. It can also cause jaw dysfunction and limited range of jaw motion, where the jaw catches or locks in a certain position. There can also be clicking or popping noises when moving the jaw, as well as jaw deviations. Because of the various causes and types of temporomandibular disorders, a diagnosis requires keen observation, especially around factors that cause or worsen the problem. It's helpful to measure the range of jaw motion, listen for irregular sounds like clicking and popping, and feeling for areas of tenderness. Plain radiographs and CT scans can show structural abnormalities or trauma, and MRIs can show changes in the articular disc and evidence of joint inflammation. Treatment of temporomandibular disorder is based on the underlying cause, but the initial goal is to help reduce pain and restore normal jaw function. Pain can be reduced by applying moist heat or cold compresses, as well as using massage, resting the muscles by eating a softer diet, and avoiding strain on the jaw, like dental work or biting on objects. Physical therapy involving jaw exercises can help with pain and range of motion. Oral appliances like splints can reduce the effects of nocturnal bruxism, and cognitive behavior therapy can address behaviors and underlying psychiatric illnesses that worsen temporomandibular disorders. Medications like muscle relaxants and non-steroidal anti-inflammatory drugs can also be used to help with pain control. In rare situations, arthroscopy can be done, which is when a small thin tube with a camera is placed into the joint space to help diagnose and treat the condition. Finally, in cases where there's a structural defect, surgery might be needed. Alright, as a quick recap, temporomandibular disorders are a group of musculoskeletal disorders that result from dysfunction in the temporomandibular joint or masticatory muscles controlling the jaw. The result is jaw pain and tenderness. A key goal of treatment is to reduce pain, and this can be done with relaxation of the jaw, as well as managing underlying problems like bruxism with oral appliances and the use of pain medications. Warthin's tumor, or Warthin tumor, is a benign, slow-growing tumor of the parotid gland named for Dr. Eldred Scott Warthin, who was the first pathologist to describe it. Normally, the parotid gland has glandular cells that make enzymes that help to break down food, as well as tiny ducts lined by epithelial cells that carry those enzymes towards the mouth. Warthin tumor's other name, papillary cystadenoma lymphomatosum, is long and technical but describes the disease pretty well. Cystadenoma refers to the fact that the ducts grow in size and fill up with serous fluid and cellular debris, which forms a large cyst. Papillary refers to the fact that the layer of epithelial cells starts to fold into the duct, which forms a finger-like projection called a papilla. Finally, lymphomatosum refers to the fact that the epithelial layer gets infiltrated by lymphocytes, which organize themselves into what look like germinal centers, which is something you'd expect to find if you looked at a cross-section of a lymph node. Looking at histology, we can see the papilla, the lymphocytes, and the cystic space where the serous fluid and the cellular debris are. Now, Warthin's tumor isn't malignant, meaning that it doesn't break through the basement membrane layer of the tissue, although there is a connective tissue capsule which usually forms around the growing tumor, which clearly demarcates it from the rest of the parotid gland. Also, that parotid gland starts to not function normally, since the ducts turn into cysts and normal epithelial cells stop functioning. Now, because a Warthin tumor is typically slow growing, it can take a bit of time before the symptoms are detected, most of which are related to the physical mass pushing up against other anatomic structures. The most common symptom is a bump or swelling in front of or below the ear, which is typically painless. There are also nerves, though, that pass through the parotid gland, which when they're pushed on can cause problems like impaired hearing, earaches, tinnitus, which is ringing in the ears, and facial paralysis. The cause of Warthin's tumor is unknown, But there are a few risk factors that have been associated with it, the strongest link being smoking. But there are other non-modifiable risk factors like being elderly, being Caucasian, and being male. Diagnosis of Warthin's tumor starts with feeling a mass around the parotid gland, followed by diagnostic imaging with an X-ray, ultrasound, CT scan, or MRI. Finally, a tissue biopsy is often done to confirm the diagnosis. The treatment of choice for Warthin's tumor is surgical removal, specifically removing as much of the tumor as possible while avoiding damage to the nerves passing through the parotid gland. Alright, as a quick recap, Warthin's tumor, also called papillary cystadenoma lymphomatosum, is a benign parotid tumor with papillae that push into cystic areas, as well as lymphocytic infiltration and germinal center formation in the epithelial layer. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media.
Esophageal cancer is when malignant or cancerous cells arise in the esophagus. This cancer can appear in any segment of the esophagus, and it's further classified into squamous cell carcinoma and adenocarcinoma, depending on the type of cells it originates from. Squamous cell carcinoma, as you can tell by its name, arises from squamous epithelium. On the other hand, adeno means gland, so adenocarcinoma arises from columnar glandular epithelium. Esophageal cancer is generally considered a poor prognosis cancer because it doesn't cause symptoms until later stages. The esophagus is a long tube going from the pharynx to the stomach, and it's connected to the pharynx through the upper esophageal sphincter, and to the stomach through the lower esophageal sphincter. Both relax during swallowing to allow the passage of foods or liquids. Additionally, the lower esophageal sphincter is tightly closed between meals to prevent acid reflux. Now, the esophageal wall has 4 layers. From the outside in, these are the adventitia, the muscular layer, the submucosa, and the mucosa. The mucosa comes in direct contact with food, and it protects the esophageal wall from friction. The mucosa also has 3 layers of its own: a layer made of stratified squamous epithelium, a layer of connective tissue called the lamina propria, and a layer of muscle cells called the muscularis mucosae. Finally, at the lower esophageal sphincter, the squamous epithelium joins the columnar gastric epithelium to form the gastroesophageal junction. Now, squamous cell carcinoma is the most common type of esophageal cancer worldwide, and it originates in the squamous epithelium of the esophagus, most often in the upper 2/3. When this epithelium is repeatedly exposed to risk factors like alcohol, cigarette smoke, or hot fluids, it gets damaged, so the squamous cells divide to replace the old damaged cells. With each division, there's a risk that a mutation can occur in the genes that are in charge of the cell cycle and cell division. Mutations can occur in tumor suppressor genes, which normally code for proteins that stop the cell cycle or promote apoptosis. So they're kind of like the cell cycle's very own brake pedal. Or they can occur in proto-oncogenes, which normally code for proteins that promote the cell cycle. So they're the cell cycle's accelerator pedal. When this happens, squamous cells start dividing uncontrollably, and more mutations accumulate with each division. So eventually, these mutations might make the cells malignant, meaning they gain the ability to invade neighboring tissues and spread to distant sites. On the other hand, adenocarcinoma is the most common type of esophageal cancer in the United States of America, and it originates in the columnar glandular epithelium. most often in the lower third of the esophagus. Most frequently, adenocarcinoma develops as a consequence of gastroesophageal reflux disease, or GERD for short. With GERD, the lower esophageal sphincter is weaker than normal, and it allows acid from the stomach to go back up into the esophagus after meals. The presence of acid in the esophagus can lead to Barrett's esophagus, which is when the squamous epithelium lining the esophagus is replaced by a columnar epithelium, similar to that of the intestines, that's better adapted to withstand the acidity. This process is called intestinal metaplasia. Over time, just like with squamous cell carcinoma, mutations might accumulate in either tumor suppressor genes or proto-oncogenes that control the division of these metaplastic cells, ultimately resulting in a malignant tumor. Risk factors for both squamous cell carcinoma and adenocarcinoma include smoking, age over 60 years, and achalasia, which is when the smooth muscle of the lower portion of the esophagus doesn't work well, making it difficult for food to pass toward the stomach. Specific risk factors for squamous cell carcinoma include alcohol consumption, hot fluids, and caustic strictures, which is the narrowing of the esophagus following ingestion of a caustic substance, like household bleach. Other predisposing conditions include Plummer-Vinson syndrome and palmoplantar keratoderma. Plummer-Vinson syndrome associates iron deficiency anemia, glossitis, or tongue inflammation, chelosis, or inflammation and cracking of the corners of the mouth, and esophageal webs or rings, which are concentric extensions of normal esophageal wall into the esophageal lumen that can cause difficulty swallowing. Palmoplantar keratoderma is a rare disease where thick patches of skin develop on the hands and feet. The strongest risk factor for adenocarcinoma, on the other hand, is chronic GERD and Barrett's esophagus. Obesity and being a genetically male individual also increases the risk of adenocarcinoma. Initially, esophageal cancer is asymptomatic, but once it progresses, the most common symptom is progressive dysphagia, which means difficulty swallowing. At first, dysphagia is specific to solid foods, but as the disease progresses, liquids are also hard to swallow. Unfortunately, this is a late symptom. Other symptoms include adenophagia, or pain when swallowing, pyrosis, which is the fancy word for heartburn, pain in the chest or back, vomiting, and weight loss. When the cancer invades and perforates the entire esophageal wall, it can invade the trachea in front of it, forming a fistula. This can cause pulmonary aspiration of esophageal contents, which may cause symptoms like coughing and dyspnea. If the cancer spreads to the diaphragm, it can cause hiccups. Diagnosis of esophageal cancer is essentially made with endoscopy, which is when a tube with a camera at the end is placed into the esophagus to directly visualize the tumor and take a biopsy. Endoscopy of the larynx, trachea, and bronchi should also be performed, since people with squamous cell carcinoma also tend to develop simultaneous head and neck cancer and lung cancer, mainly because these cancers share the same risk factors like smoking, alcohol consumption, and obesity. Chest CT can be used to evaluate if the cancer has spread to nearby lymph nodes. X-rays with barium contrast of the upper GI tract can be useful to identify the location of the cancer and complications like ulcers or esophageal stenosis. A positron emission tomography, or PET for short, is useful to see if the cancer has metastasized and to evaluate the response to chemotherapy. Following imaging studies, esophageal cancer is staged according to the TNM system, where T means tumor size and local extension, N stands for lymph node metastases, and M stands for distant metastases. Each of these categories have substages, so from T0 to T4, from N0 to N3, and M0 to M1, and the combinations of these substages determine the esophageal cancer stage, from 0 to 4. And the higher the number, the more the cancer has invaded and spread. So for example, if a tumor has invaded the esophageal submucosa, but it hasn't spread to lymph nodes or distant organs, it's categorized as T1, N0, M0, which falls under stage 1. But if there are any distant metastases, translating as M1, the tumor is considered stage 4, regardless of T and N status. Treatment depends on the stage. For initial stages, when the cancer has invaded just the mucosa and submucosa, options include esophagectomy, endoscopic tumor resection, or mucosal ablation, which is when the cancerous mucosa is removed by radiofrequency. For more advanced stages, chemoradiotherapy is used in combination with surgery. Unfortunately, esophageal cancer is usually diagnosed in advanced stages, so it's considered a poor prognosis cancer. When the cancer is incurable, palliative treatment with an esophageal stent, which is a tiny tube placed inside the esophagus to keep it dilated, usually helps reduce dysphagia. Alright, as a quick recap, esophageal cancer is the uncontrolled growth of esophageal epithelial cells. Risk factors for both types of cancer include smoking, age over 60 years, and achalasia. Squamous cell carcinoma arises from the stratified squamous epithelium. Specific risk factors include alcohol, hot fluids, caustic strictures, Plummer-Vinson syndrome, and palmoplantar keratoderma. Adenocarcinoma arises from columnar epithelium. Barrett's esophagus and chronic GERD are the most important risk factors. Symptoms include dysphagia, odynophagia, vomiting, and chest or back pain. Diagnosis is made with endoscopy and biopsy. Chest CT, X-rays with barium contrast of the upper GI tract, and PET are used for further evaluation. The treatment depends on the stage. For initial stages, esophagectomy and tumor resection are sufficient. For more advanced stages, there's chemoradiotherapy combined with surgery. Esophageal cancer is when malignant or cancerous cells arise in the esophagus. This cancer can appear in any segment of the esophagus, and it's further classified into squamous cell carcinoma and adenocarcinoma, depending on the type of cells it originates from. Squamous cell carcinoma, as you can tell by its name, arises from squamous epithelium. On the other hand, adeno means gland, so adenocarcinoma arises from columnar glandular epithelium. Esophageal cancer is generally considered a poor prognosis cancer because it doesn't cause symptoms until later stages. The esophagus is a long tube going from the pharynx to the stomach, and it's connected to the pharynx through the upper esophageal sphincter, and to the stomach through the lower esophageal sphincter. Both relax during swallowing to allow the passage of foods or liquids. Additionally, the lower esophageal sphincter is tightly closed between meals to prevent acid reflux. Now, the esophageal wall has 4 layers. From the outside in, these are the adventitia, the muscular layer, the submucosa, and the mucosa. The mucosa comes in direct contact with food, and it protects the esophageal wall from friction. The mucosa also has 3 layers of its own: a layer made of stratified squamous epithelium, a layer of connective tissue called the lamina propria, and a layer of muscle cells called the muscularis mucosae. Finally, at the lower esophageal sphincter, the squamous epithelium joins the columnar gastric epithelium to form the gastroesophageal junction. Now, squamous cell carcinoma is the most common type of esophageal cancer worldwide, and it originates in the squamous epithelium of the esophagus, most often in the upper 2/3. When this epithelium is repeatedly exposed to risk factors like alcohol, cigarette smoke, or hot fluids, it gets damaged, so the squamous cells divide to replace the old damaged cells. With each division, there's a risk that a mutation can occur in the genes that are in charge of the cell cycle and cell division. Mutations can occur in tumor suppressor genes, which normally code for proteins that stop the cell cycle or promote apoptosis. So they're kind of like the cell cycle's very own brake pedal. Or they can occur in proto-oncogenes, which normally code for proteins that promote the cell cycle. So they're the cell cycle's accelerator pedal. When this happens, squamous cells start dividing uncontrollably, and more mutations accumulate with each division. So eventually, these mutations might make the cells malignant, meaning they gain the ability to invade neighboring tissues and spread to distant sites. On the other hand, adenocarcinoma is the most common type of esophageal cancer in the United States of America, and it originates in the columnar glandular epithelium, most often in the lower third of the esophagus. Most frequently, adenocarcinoma develops as a consequence of gastroesophageal reflux disease, or GERD for short. With GERD, the lower esophageal sphincter is weaker than normal, and it allows acid from the stomach to go back up into the esophagus after meals. The presence of acid in the esophagus can lead to Barrett's esophagus, which is when the squamous epithelium lining the esophagus is replaced by a columnar epithelium, similar to that of the intestines, that's better adapted to withstand the acidity. This process is called intestinal metaplasia. Over time, just like with squamous cell carcinoma, mutations might accumulate in either tumor suppressor genes or proto-oncogenes that control the division of these metaplastic cells, ultimately resulting in a malignant tumor. Risk factors for both squamous cell carcinoma and adenocarcinoma include smoking, age over 60 years, and achalasia, which is when the smooth muscle of the lower portion of the esophagus doesn't work well, making it difficult for food to pass toward the stomach. Specific risk factors for squamous cell carcinoma include alcohol consumption, hot fluids, and caustic strictures, which is the narrowing of the esophagus following ingestion of a caustic substance, like household bleach. Other predisposing conditions include Plummer-Vinson syndrome and palmoplantar keratoderma. Plummer-Vinson syndrome associates iron deficiency anemia, glossitis, or tongue inflammation, cheilosis, or inflammation and cracking of the corners of the mouth, and esophageal webs or rings, which are concentric extensions of normal esophageal wall into the esophageal lumen that can cause difficulty swallowing. Palmoplantar keratoderma is a rare disease where thick patches of skin develop on the hands and feet. The strongest risk factor for adenocarcinoma, on the other hand, is chronic GERD and Barrett's esophagus. Obesity and being a genetically male individual also increases the risk of adenocarcinoma. Initially, esophageal cancer is asymptomatic, but once it progresses, the most common symptom is progressive dysphagia, which means difficulty swallowing. At first, dysphagia is specific to solid foods, but as the disease progresses, liquids are also hard to swallow. Unfortunately, this is a late symptom. Other symptoms include adenophagia, or pain when swallowing, pyrosis, which is the fancy word for heartburn, pain in the chest or back, vomiting, and weight loss. When the cancer invades and perforates the entire esophageal wall, it can invade the trachea in front of it, forming a fistula. This can cause pulmonary aspiration of esophageal contents, which may cause symptoms like coughing and dyspnea. If the cancer spreads to the diaphragm, it can cause hiccups. Diagnosis of esophageal cancer is essentially made with endoscopy, which is when a tube with a camera at the end is placed into the esophagus to directly visualize the tumor and take a biopsy. Endoscopy of the larynx, trachea, and bronchi should also be performed, since people with squamous cell carcinoma also tend to develop simultaneous head and neck cancer and lung cancer, mainly because these cancers share the same risk factors like smoking, alcohol consumption, and obesity. Chest CT can be used to evaluate if the cancer has spread to nearby lymph nodes. X-rays with barium contrast of the upper GI tract can be useful to identify the location of the cancer and complications like ulcers or esophageal stenosis. A positron emission tomography, or PET for short, is useful to see if the cancer has metastasized and to evaluate the response to chemotherapy. Following imaging studies, esophageal cancer is staged according to the TNM system, where T means tumor size and local extension, N stands for lymph node metastases, and M stands for distant metastases. Each of these categories have substages, so from T0 to T4, from N0 to N3, and M0 to M1, and the combinations of these substages determine the esophageal cancer stage, from 0 to 4. And the higher the number, the more the cancer has invaded and spread. So for example, if a tumor has invaded the esophageal submucosa, but it hasn't spread to lymph nodes or distant organs, it's categorized as T1, N0, M0, which falls under stage 1. But if there are any distant metastases, translating as M1, the tumor is considered stage 4, regardless of T and N status. Treatment depends on the stage. For initial stages, when the cancer has invaded just the mucosa and submucosa, options include esophagectomy, endoscopic tumor resection, or mucosal ablation, which is when the cancerous mucosa is removed by radiofrequency. For more advanced stages, chemoradiotherapy is used in combination with surgery. Unfortunately, esophageal cancer is usually diagnosed in advanced stages, so it's considered a poor prognosis cancer. When the cancer is incurable, palliative treatment with an esophageal stent, which is a tiny tube placed inside the esophagus to keep it dilated, usually helps reduce dysphagia. Alright, as a quick recap, esophageal cancer is the uncontrolled growth of esophageal epithelial cells. Risk factors for both types of cancer include smoking, age over 60 years, and achalasia. Squamous cell carcinoma arises from the stratified squamous epithelium. Specific risk factors include alcohol, hot fluids, caustic strictures, Plummer-Vinson syndrome, and palmoplantar keratoderma. Adenocarcinoma arises from columnar epithelium. Barrett's esophagus and chronic GERD are the most important risk factors. Symptoms include dysphagia, odynophagia, vomiting, and chest or back pain. Diagnosis is made with endoscopy and biopsy. Chest CT, X-rays with barium contrast of the upper GI tract, and PET are used for further evaluation. The treatment depends on the stage. For initial stages, esophagectomy and tumor resection are sufficient. For more advanced stages, there's chemoradiotherapy combined with surgery.
Gastroesophageal reflux disease, or GERD for short, is a condition where the lower esophageal sphincter is abnormally relaxed, allowing acid contents from the stomach to enter the esophagus and damage its mucosa. Now, based on clinical manifestations, a person with GERD can present with alarm, typical, and atypical signs and symptoms. First, you should suspect GERD when a patient complains of epigastric burning that radiates under the sternum, also called pyrosis or heartburn, and a sour or bitter taste in the mouth caused by acid regurgitation. If that's the case, the next step should be to assess alarm signs and symptoms, which are typically associated with complications of GERD. Start by obtaining a focused history and physical examination. History typically reveals chest pain, persistent severe heartburn, dysphagia, odynophagia, unintentional weight loss, melena, frequent vomiting, and even hematemesis. At the same time, a physical exam might reveal general discomfort, pallor, or evidence of GI bleeding. For example, the patient might vomit blood right in front of you. Now, in order to confirm the suspected complications of GERD, you should order an esophagogastroduodenoscopy, or EGD for short, with biopsies, and get some blood work, including a CBC and iron studies. If the EGD, biopsies, and blood work are normal, you should consider an alternative diagnosis. On the flip side, the EGD may often reveal pathologic findings. For example, the biopsy might show tongues of pink mucosa with columnar metaplasia, which suggests Barrett esophagus. On the other hand, it might reveal friable, erythematous epithelium with inflammatory cells, which suggests erosive esophagitis. Additionally, important endoscopic findings might include an esophageal mass or peptic strictures. But that's not all. The patient's blood work might reveal microcytic anemia with iron deficiency. These findings confirm a diagnosis of GERD complications, so you should treat the patient with antacids like proton pump inhibitors or PPIs, and recommend lifestyle modifications like smoking cessation. Don't forget to treat anemia if it's present. Additionally, a surgical consult might suggest esophageal dilation, endoscopic ablation, or laparoscopic fundoplication. Esophageal dilation is used to stretch the walls of the esophagus and relieve symptoms of dysphagia, while endoscopic ablation treats precancerous lesions caused by chronic reflux of gastric contents. Finally, laparoscopic fundoplication involves wrapping the top part of the stomach around the lower portion of the esophagus, forming an artificial valve that prevents reflux. An important fact to keep in mind is that Barrett esophagus has a high risk of transitioning into esophageal adenocarcinoma, so these individuals will need regular EGD screenings. Alright, now let's move on to individuals that present with typical GERD symptoms. Their history commonly reveals heartburn and a sour or bitter taste in the mouth. The physical exam is usually normal. However, an oral exam might reveal dental erosions or halitosis. If so, you should start empiric treatment prior to diagnostic workup. Empiric treatment includes antacid medications such as proton pump inhibitors like omeprazole or histamine 2 receptor blockers like famotidine. Proton pump inhibitors cause greater acid suppression than H2 receptor blockers, so they are usually preferred. Additionally, all individuals with suspected or diagnosed GERD should receive counseling on lifestyle modifications, like tobacco cessation and weight loss. Now, if the individual responds well to this medical therapy, this confirms the clinical diagnosis of typical GERD. The patient should continue the current medical therapy and get an EGD after 1 year to evaluate for conditions like Barrett esophagus and establish the best long-term management plan. On the other hand, if there's no improvement after empiric therapy, then stop the current medication for 7 to 14 days and perform an EGD with biopsies to rule out complications of GERD. If the patient presents with an abnormal EGD with biopsies, this confirms the diagnosis of GERD complications, so treat accordingly. Now, if the EGD and biopsies are normal, meaning there is no pathology found, you still cannot rule out GERD until you check a 24-hour esophageal impedance study with pH monitoring. This test will give you quantitative data on how often the esophagus is being exposed to stomach acid. The results are broken down into normal and abnormal based on the number of reflux events in a 24-hour period and the pH of the contents. Normal findings include 40 or fewer reflux events with a pH of 4 or greater. A normal test rules out GERD, and you should consider an alternative diagnosis for these individuals. In contrast, abnormal findings include more than 40 reflux events with an acidic pH of less than 4. If you see this, you can diagnose these individuals with typical GERD. As before, the treatment should consist of antacid therapy, lifestyle modification, and a surveillance EGD in 1 year. Finally, let's move on to individuals that present with atypical GERD symptoms. On history, they usually report extraintestinal symptoms such as cough, hoarseness, or throat clearing. A physical exam may reveal wheezing on lung auscultation, as well as oropharyngeal changes such as erythema, dental erosions, or halitosis. Now, if the patient also reports classic GERD symptoms, such as heartburn, then you should definitely suspect atypical GERD. In this case, you can start empiric antacid therapy and lifestyle modifications. If this relieves the patient's symptoms, it confirms the diagnosis of atypical GERD. Then you can continue the current treatment and schedule an EGD in 1 year. On the other hand, if there's no response to empiric medical therapy, you should order an EGD with biopsies. If the EGD with biopsies is abnormal, then it confirms the diagnosis of GERD complications. If the EGD is normal, you should order esophageal impedance and pH monitoring. If the results are normal, you can rule out GERD and consider alternative diagnoses. However, if it is abnormal, it confirms the diagnosis of atypical GERD. You should continue to treat with antacid therapy, lifestyle modification, and a surveillance EGD in 1 year. Okay, now let's go back to a patient that presents with only atypical GERD symptoms and no typical symptoms. Before you do a GI workup, you should evaluate for other diagnoses, such as laryngitis or asthma. If none are found, then you can proceed with testing for atypical GERD. First, get an EGD with biopsies. If the results are abnormal, it confirms the diagnosis of GERD complications. Now, if the EGD and biopsies are normal, you should proceed with esophageal impedance and pH monitoring. If this is normal, then you should consider alternative diagnoses. However, if this test is abnormal, it confirms the diagnosis of atypical GERD, and you can begin treatment with antacid medications, lifestyle modifications, and a repeat EGD in a year. Alright, as a quick recap, based on history and physical findings, a patient with GERD can present with alarm, typical, or atypical signs and symptoms. In individuals that present with alarm symptoms, order labs and an EGD with biopsy to rule out other conditions and identify GERD complications like Barrett esophagus or erosive esophagitis. You can typically treat GERD complications with antacid therapy, lifestyle modifications, and surgical interventions, such as esophageal dilation and laparoscopic fundoplication. On the other hand, you can treat patients who have typical GERD symptoms with antacid therapy and lifestyle modifications. If their symptoms persist, order an EGD with biopsies to rule out GERD complications and obtain a 24-hour esophageal impedance and pH monitoring. Abnormal findings on esophageal impedance and pH monitoring confirm the diagnosis of typical GERD, so continue the current treatment. Similarly, patients who present with both typical and atypical GERD symptoms also require antacid therapy and lifestyle modifications. On the other hand, if a patient presents with only atypical GERD symptoms, you should first rule out alternate diagnoses. If no other diagnosis is found, proceed with an EGD with biopsies to rule out GERD complications, and order a 24-hour esophageal impedance and pH monitoring study to confirm the diagnosis of atypical GERD. In atypical GERD, the treatment also includes antacid therapy and lifestyle modifications. Finally, all individuals with GERD require regular follow-ups with EGD to assess for complications.
Gastro refers to the stomach, esophageal stands for esophagus, and reflux means to flow back. So gastroesophageal reflux disease, or GERD, is when stomach acid flows back into the esophagus. The presence of acid in the esophagus can lead to Barrett's esophagus, a serious complication of GERD where the normal mucosa of the esophagus is replaced by one that's similar to that of the intestines. Barrett's esophagus poses a higher risk of developing esophageal adenocarcinoma. Normally, the wall of the entire gastrointestinal tract is made of 4 layers: the inner mucosa, the submucosa, a muscular layer, and an outer layer called the adventitia. The mucosa is further divided into 3 layers: an innermost epithelial layer, a middle layer called the lamina propria, and an outermost layer, in contact with the submucosa, called the muscularis mucosa, which is made up of smooth muscle that contracts and helps with the breakdown of food. Now, the stomach mucosa is different from the esophageal mucosa. Inside the stomach, the epithelial layer is made up of cylindrical cells, which dive into the lamina propria, forming pits. These pits are the gastric glands, and there are many of them scattered throughout the stomach. Distributed among the cylindrical gland cells, there's different types of secretory cells. First, there's G cells, which are a type of neuroendocrine cells that secrete a hormone called gastrin in response to food entering the stomach. Gastrin stimulates another type of cells, the parietal cells, to release hydrochloric acid. And then there's chief cells, which secrete an enzyme called pepsinogen. Hydrochloric acid and pepsinogen are useful for digestion, but they can be quite aggressive for the delicate mucosa. Luckily though, the stomach also has some defense mechanisms in place. First, the gastric glands also have foveolar cells, also called surface mucus cells, because they are closer to the surface of the stomach and they secrete mucus. Mucus is mostly made up of water and glycoproteins, and also bicarbonate ions, which are also secreted by foveolar cells. This bicarbonate-rich mucus protects the gastric mucosa from our own gastric acid, so it won't get digested along with food. Lastly, the gastric mucosa is highly vascularized, which helps deliver oxygen and bicarbonate and carry away acid that makes it through into the lamina propria. The esophagus, on the other hand, is better adapted for the passage of food, so its mucosa is made up of stratified squamous epithelium, which is better equipped to resist abrasion from food going down. The downside is that this kind of epithelium doesn't have defense mechanisms like the stomach, so it's more susceptible to acid damage. So, to protect the esophageal mucosa, at the lower end of the esophagus, there's the lower esophageal sphincter, or LES, which is a circular muscle that relaxes when we swallow to allow the passage of food, and closes between meals to prevent acid reflux. The lower esophageal sphincter has a resting pressure of 10 to 45 millimeters of mercury. When the pressure is lower than normal, which means the sphincter becomes looser, gastric acid reaches the esophagus and the pH of the esophagus drops to around 4, which is called acid reflux. Some esophageal defense mechanisms against acid reflux are the primary and secondary peristaltic waves. Some degree of acid reflux is normal, especially after meals, but it doesn't last long since secondary peristaltic waves, which are contractions of the esophageal muscle layer that happen a while after we've already swallowed, push the gastric acid back into the stomach. Finally, saliva also helps neutralize the acidic gastric content. Now, when the pressure of the lower esophagus gets lower for some reason, reflux persists for longer, becoming pathological. Persistent acid reflux damages the esophageal mucosa, causing local inflammation or esophagitis. Esophagitis, in turn, causes edema and erosion of the mucosa, which leads to more complications. First off, every time the epithelium and the underlying tissue is damaged, it's replaced by a scar. Since this is continuously happening, the scar becomes bigger and bigger, and together with the edema, they turn the wall thicker and the lumen through which the food passes becomes smaller, which is called esophageal stenosis. Also, when the epithelium is continuously damaged and replaced, the new epithelium of the lower esophagus is gradually replaced by a single layer of columnar cells, similar to intestinal cells that are more adapted to withstand the reflux. This is called Barrett's esophagus, or Barrett's metaplasia, and the cylindrical epithelium has a greater risk of degenerating into a particular type of esophageal cancer, called adenocarcinoma. Another complication is when the reflux goes all the way back up to the pharynx and then into the larynx, in which case it can cause laryngitis or even asthma. Risk factors for developing GERD are factors that weaken the lower esophageal sphincter, like obesity, a fat-rich diet, caffeine, alcohol, and smoking. There's also medications like antihistamines, calcium channel blockers, antidepressants, benzodiazepines, and glucocorticoids. Medical conditions that increase the risk for GERD include hiatal hernia, scleroderma, and Zollinger-Ellison syndrome. In hiatal hernia, the stomach and lower part of the esophagus slide up through the esophageal hiatus, which is an orifice in the diaphragm, and this decreases the pressure of the lower esophageal sphincter. In scleroderma, the muscle of the lower esophageal sphincter is replaced by connective tissue, so it can't contract properly. In Zollinger-Ellison syndrome, a tumor called a gastrinoma secretes large amounts of gastrin that stimulates hydrochloric acid secretion in excess, and makes reflux even worse. Okay, now the most common symptom of chronic gastroesophageal reflux disease is pyrosis, also called heartburn, which is a burning pain in the chest just behind the breastbone. Another common symptom is regurgitation, where undigested food and a bit of gastric acid go back up into the mouth, and can cause acidic taste or even damage of the enamel layer of the teeth. With stenosis, there may be dysphagia, which is a fancy way to say difficulty swallowing. And if reflux goes into the respiratory tract, GERD might also present with chronic cough or hoarseness. All of these symptoms, especially heartburn and regurgitation, worsen when lying down. Most commonly, GERD is diagnosed based on the clinical symptoms, and a therapeutic challenge is done. This means that proton pump inhibitors, which are medications that inhibit acid secretion, are given, and with GERD, symptoms improve. However, the most accurate study to diagnose GERD is a 24-hour pH monitoring in the lower esophagus, where a thin tube with an electrode attached is placed inside the esophagus in order to detect how long the acid reflux stays in there. X-rays with barium contrast of the upper GI tract can be useful to identify complications like ulcers or esophageal stenosis. Also, an endoscopy, which is when a tube with a camera at the end is placed into the esophagus, and a biopsy are essential to diagnose Barrett's esophagus and to evaluate the risk of cancer. If the biopsy shows normal intestinal cells under the microscope and there are signs of inflammation, this is called non-dysplastic Barrett's, and the risk of developing esophageal cancer is very low. However, if the cells look abnormal, that's called dysplasia, and there's a higher risk of developing adenocarcinoma. Lifestyle changes, antacids, and proton pump inhibitors are the first-line treatment for GERD. Lifestyle changes include losing weight in overweight individuals and avoiding spicy, fatty foods, chocolate, coffee, and alcohol. Additionally, keeping the head elevated during sleep and not lying down immediately after a meal are recommended. Medications include antacids, which neutralize the acidity of gastric secretions, and proton pump inhibitors, as well as H2 receptor blockers, which decrease hydrochloric acid production in the first place. Other choices include prokinetic medications, which increase the tone of the lower esophageal sphincter, and the GABA agonist baclofen, which inhibits transient LES relaxations, especially after meals. Surgery can be done when pharmacological treatment is not effective, and the most common procedure is Nissen fundoplication, where the gastric fundus is wrapped around the lower esophageal sphincter in order to make it tighter. Finally, for Barrett's metaplasia, there's different treatments depending on the stage. Non-dysplastic can be followed up with an endoscopy every 3 years. In case of dysplasia, there's options like surgery, endoscopic resection, or laser treatments. Alright, as a quick recap, gastroesophageal reflux disease, or GERD, is a condition where a decreased tone of the lower esophageal sphincter causes an excessive amount of stomach acid to flow back into the esophagus. This causes the epithelium of the lower esophagus to constantly renew, and when it's replaced by columnar epithelium, that's called Barrett's esophagus. Risk factors for GERD include obesity, a fat-rich diet, caffeine, alcohol, and smoking. Symptoms include heartburn, regurgitation, or dysphagia. Mucosal damage can cause inflammation or esophagitis, which can lead to complications like stenosis and Barrett's esophagus. Diagnosis can be done based on clinical symptoms, but the gold standard is 24-hour pH monitoring. An endoscopy and biopsy can be done to diagnose Barrett's esophagus. Treatment includes lifestyle changes and medications like antacids and proton pump inhibitors. For Barrett's esophagus, treatment depends on the stage of the metaplasia.
With a retropharyngeal and peritonsillar abscess, an abscess is a collection of pus, and retropharyngeal and peritonsillar describes where the abscess is found. A retropharyngeal abscess develops behind the pharynx, in the tissue that lies just behind the back of the throat. A peritonsillar abscess develops around the tonsils, particularly the palatine tonsils, which are at the back of the throat. Let's start by better defining the location of these spaces. The retropharyngeal space is the region between the pharynx and the vertebrae, and is bound posteriorly, closer to the vertebrae, by the alar fascia, and anteriorly, or closer to the pharynx, by the buccopharyngeal fascia. These fascial layers are thin fibrous layers that coat muscles, tendons, and bones. And between them and the retropharyngeal space are lymph nodes. These lymph nodes are like surveillance stations that bring in lymphatic fluid from the throat and other nearby tissue. If there are pathogens in that lymphatic tissue, immune cells in the lymph node can respond and try to destroy the invading pathogens. Next is the peritonsillar region, which refers to the palatine tonsils. The palatine tonsils are on either side of the oral pharynx and are attached to the soft palate at the back of the oral cavity. They're basically dense collections of lymphatic tissue wrapped within a fibrous capsule, like tiny lymph burritos, and they help defend against pathogens in the food and air. When pathogens like bacteria invade tissues in the mouth, they're brought to nearby lymph nodes. When the retropharyngeal lymph nodes or palatine lymph nodes receive a pathogen, it activates an immune response. Oftentimes, the first immune cells at the scene are neutrophils, which release chemicals and enzymes that kill bacteria and dissolve pieces of dead cells, creating a pool of dead material. This is a specific type of acute inflammatory response called suppurative inflammation, which just means that pus is created in the process. From a macroscopic view, this is sometimes referred to as a liquefactive necrosis, because the area of dead tissue turns to liquid. As those immune cells get to a point where they can't withstand the environment, they die too, and become part of the pool. Initially, the debris might be intermixed with healthy tissue, but over time it can coalesce into a single area, a process that's often sped up when more immune cells get involved. Around this pool of pus, a wall of fibrinogen, which is the same protein that holds together blood clots, starts to harden into a barrier. Occasionally, sheets of fibrin form septations, creating loculations or pockets of pus within the abscess itself, kind of like an abscess within an abscess. Even though the pus is largely dead material, there are still plenty of live bacteria within the pus, which makes it highly infectious if it gets spread from one place to another. As the abscess grows, it can press against nearby structures. Both retropharyngeal and peritonsillar abscesses can start to press into the pharynx. At that point, the abscess becomes especially problematic because it can obstruct the upper airway and become life-threatening. These infections can also spread into the lymphatic system. Retropharyngeal infections can spread downward into the mediastinum and pericardium, and peritonsillar infections can spread to the tongue, soft palate, and pharyngeal space. The infection could also spread systemically through the blood, and it can lead to a massive inflammatory response called sepsis. Both retropharyngeal and peritonsillar abscesses are typically caused by a mix of bacteria, often including Staphylococcus aureus, Group A Streptococci, and Haemophilus parainfluenzae. Interestingly, retropharyngeal abscesses are most common among toddlers and young children, whereas peritonsillar abscesses typically affect older children and adults. The most common symptoms of both a retropharyngeal and peritonsillar abscess are fever and severe throat pain or stiffness. Sometimes there's a large mass that causes pharyngeal obstruction, or pain with swallowing, And in severe cases, there can be signs of airway obstruction, like a high-pitched noise on inspiration called stridor, and retractions, which is where ribs show through as they breathe. Diagnosis of peritonsillar or retropharyngeal abscess can be made with an X-ray or CT scan, both of which would show the collection of pus within the tissue. If there's any drainage, it can be sent off for tissue culture to reveal the cause of the abscess. Blood tests can reveal signs of an infection, like an increased number of immune cells, like neutrophils, and blood cultures can help to find the cause if the bacteria is in the bloodstream. Typically, a large abscess that might be obstructing the airway needs to be surgically drained. In addition, antibiotics can help treat the infection, and steroids are sometimes helpful in quickly reducing the inflammation. If peritonsillar abscesses keep developing, sometimes a tonsillectomy can be done to help prevent a recurrence. Alright, as a quick recap. Retropharyngeal or peritonsil abscesses are collections of pus in the retropharyngeal space or the palatine tonsils, respectively. The most common causes are Staphylococcus aureus, group A streptococci, and Haemophilus parainfluenzae. And the key treatment is surgical drainage, antibiotics, and steroids, particularly in situations where there's a lot of inflammation that obstructs the airway. Sleep apnea is a sleep disorder which causes irregular breathing and snoring patterns that can ultimately cause apnea, which is where a person momentarily stops breathing altogether. The inability to get restful sleep can also lead to severe exhaustion. Individuals can have obstructive sleep apnea, central sleep apnea, or features of both. Obstructive sleep apnea is the most common form, and it develops when there's a blockage of the airways. Now, air has to go from the nose through the nasopharynx into the laryngopharynx, through the larynx, and then into the trachea. Somewhere along that path, there might be a blockage in the flow of air. Allergies might cause swelling in the tissues of the nasopharynx, or there might be swollen adenoid glands or tonsils because of an infection. There might be a severe overbite, which pulls the jaw back and blocks the airway. In individuals that are overweight, there could be too much weight in the soft tissues of the neck, which can weigh down the airway, especially when a person's lying down. These problems are most obvious at night, because hormonal changes at night cause the muscles around the airway to become slightly less stiff while sleeping. This means that they're less able to keep the airway open, making it more likely to get a bit squashed or obstructed. Central sleep apnea, on the other hand, refers to the fact that the problem's central or related to the central nervous system. This is where the brain intermittently stops making an effort to breathe for 10 to 30 seconds. The apnea can persist for several seconds even after waking up, triggering feelings of panic and further disrupting the sleep cycle. Central sleep apnea starts with an initial episode of hyperpnea, which is when the brain directs the lungs to start hyperventilating during sleep by increasing the respiratory rate. This rapid breathing causes hypocapnia, a drop in the blood's carbon dioxide levels. When the carbon dioxide levels fall below a certain threshold, the body slips into a state of apnea, making no effort to breathe and taking in no oxygen. This causes the carbon dioxide levels to rise back to normal levels, and then, as the apnea persists, they keep rising to a point where it's called hypercapnia. The really high carbon dioxide levels triggers hyperpnea again, and the cycle starts all over. Essentially, the respiratory system is going rapidly back and forth between two states, first making no effort to breathe and then hyperventilating, with no in-between. The most common symptom of sleep apnea is severe sleep deprivation. Interrupted sleep can cause nocturia, the excessive need to urinate during the night, and stress-induced insomnia. The effects are also apparent during the day, because the loss of restful sleep leads to difficulty concentrating, headaches, and fatigue. Apneic episodes are usually preceded by loud snoring, which can interrupt the sleep of other people as well. Sleep apnea on its own is rarely fatal, but it can worsen other health problems. For example, drops in oxygen levels can trigger anginal chest pain, and can irritate heart cells leading to an arrhythmia, an irregular heartbeat. Broadly speaking, individuals with sleep apnea have a higher risk for heart failure, respiratory failure, diabetes, and certain types of cancer. Diagnosing sleep apnea requires a sleep study to help identify episodes of sleep apnea. The more episodes, the more severe the sleep apnea. A sleep study usually involves getting monitored overnight with a polysomnogram. A polysomnogram tracks things like brain movement, oxygen and carbon dioxide levels, vital signs, and outward symptoms like snoring and movement. Treating sleep apnea starts with avoiding things like sleeping pills, alcohol, and other depressant medications because they can relax the throat muscles around the airways and make the airways more likely to collapse during sleep. In addition, sleeping on the side instead of on the back can also help because it creates better airflow into the lungs. For severe sleep apnea, individuals can use a continuous positive airway pressure device, or CPAP device for short. This machine forces the airways open with a steady stream of pressurized air delivered through a plastic face mask or nasal prongs. Used properly, this is really effective, but it requires continuous use. Many people eventually stop using it, finding it annoying or difficult to wear, and so the problem persists. Some people with obstructive sleep apnea can benefit from custom-made oral mouthpieces that help improve airflow during sleep. Sometimes obstructive sleep apnea can be managed surgically, for example, removing large adenoid tissue or realigning the jawbone. These procedures, though, can be complicated because the anesthesia and surgical swelling can both worsen sleep apnea in the short term. Alright, as a quick recap. Sleep apnea can be due to physical obstruction of the airway or from a neurological malfunction initiated by imbalances in the blood's oxygen and carbon dioxide levels, which regulate breathing cycles. Left untreated, the condition can interact negatively with other underlying health conditions, leading to serious complications.